I just want to welcome everybody tonight to Hope Connections educational program, updates on breast cancer research at the San Antonio Breast Cancer Symposium. And it's my pleasure to introduce our speaker, Dr. Jenny Shang. Dr. Shang is an assistant professor in the Department of Oncology at the Johns Hopkins University School of Medicine. Her areas of clinical expertise include internal medicine and oncology. Caring for men and women with cancer, she addresses living with, through, and beyond cancer. As she primarily treats patients with breast cancer, she discusses the best treatment options, manages symptoms from cancer and treatment-related side effects, and focuses on psychosocial aspects of care. In keeping with comprehensive survivorship care, she plans surveillance and screening, encourages health promotion, including diet, exercise, and interpersonal relationships, and care coordination. Dr. Shang, we're thrilled to have you here with us today, and I'm going to turn it over to you.
Thanks so much for that introduction, Stephanie. I'm going to share my screen now, and hopefully all of y'all will be able to see the slides that I prepared. Let me know if you see my presentation screen. I'm getting a thumbs up. Are you seeing the major slideshow or are you seeing my individual slides?
I'm seeing both, seeing the major one up front, and then you have the sides, with each slide on the side.
All right, let me try to share this one more time. My apologies. All right, please let me know if you see the slide.
It looks great.
It's not really presenting in my usual fashion, so I will try this one more time. I do apologize. Usually it looks a little different when I do it, so just one moment. All right, Stephanie, please let me know if that looks correct.
Yeah, I think that looks good.
All right, excellent. Good evening, everyone. My name is Jennifer Shang. I'm an assistant professor of oncology at the Sidney Kimmel Comprehensive Cancer Center, specifically at Sibley Memorial Hospital. Today, I'll be talking about the top 10 clinical trials that were presented at the San Antonio Breast Cancer Symposium in 2022. There are obviously numerous abstracts and presentations, but I'm really focusing on the ones that I felt like were most clinically impactful. Before we jump into talking about those clinical trials, I do want to touch on some background. It's important for us to talk about the subtypes of breast cancer, staging, and the general types of medical oncology treatments, also known as systemic therapies for breast cancer. In terms of definitions, we'll start with hormone receptor positive breast cancer. So typically, breast cancer biopsy samples are stained in the lab to evaluate for estrogen receptor, also known as ER, and progesterone receptor expression. We use the American Society of Clinical Oncology guidelines, as well as the College of American Pathologists guidelines to define this ER and PR as at least 1% staining. We think that there's likely benefit from hormonal, also known as endocrine therapies, if the stain is at least 10%. Now we'll move on to the definition for HER2 positive. These breast cancer biopsy samples are tested in the lab to evaluate for HER2 expression. HER2 is human epidermal growth factor receptor 2. It's a gene that's responsible for producing HER2 proteins. And we use techniques called immunohistochemistry and fluorescent in situ hybridization, also known as FISH, to help define these. These guidelines are quite complex, and you can kind of see from these very tiny images that there are lots of pathways. Essentially, our pathologists spend a lot of time combing through the microscope slides to help us determine the HER2 status and then sending off FISH when it's appropriate. And triple negative breast cancer means that there is no estrogen receptor, progesterone receptor, or HER2 expression on a breast cancer cell. In terms of staging, it's important because it describes the extent of disease and it's providing prognostic information. It's often a component of eligibility for trials, and there are quite a few key factors that we use to determine the appropriate stage. Those include tumor size, lymph node involvement, distant metastases, grade, hormone receptor status, and HER2 status. So stage 0 is specifically in situ or non-invasive breast cancer. Early stage is typically 1 and 2. Locally advanced is 3, and advanced or metastatic is 4. In terms of the types of medical oncology treatments that we use, these include chemotherapy, endocrine, also known as hormonal therapy, targeted therapies, specifically HER2 targeted therapy, cyclin-dependent kinase, also called CDK inhibitors, mTOR inhibitors, PARP inhibitors, PIK3CA inhibitors, as well as immunotherapy and antibody drug conjugates. In terms of terminology, that's important to understand regarding the timing of therapy in early stage breast cancer, which is considered stage 1 through 3. We have adjuvant systemic therapy, so those are treatments given after surgery to reduce the risk of cancer returning, such as the risk of metastases. And there's also neoadjuvant systemic therapy. These are treatments that are given before surgery to help shrink a tumor, to gain prognostic information about likelihood of recurrence, gaining information to guide adjuvant therapy decisions, and to also just overall reduce the risk of cancer returning, known as recurrence. Lastly, we have post-neoadjuvant systemic therapy. These are treatments given after surgery to a patient who previously received neoadjuvant treatment before surgery. And lastly, in the background section, because we are focusing on clinical trials, it's important to know what each of these phases involves. So all the way on the left, you'll see a little microscope. Those are really the early discoveries that are going on in a lab. It's usually preclinical research. Then a phase 1 study is really looking at safety and best dosage levels. Usually there are just a handful of participants in a phase 1. A phase 2 is looking at response to new treatment, and that's really looking at efficacy. And for instance, a lot of times those studies include less than 100 patients. Phase 3 studies are much larger. These results are really meant to help gain regulatory approval, such as the FDA. These usually have over 100 participants. And lastly, there is phase 4. You don't hear about it too much because oftentimes drugs are approved after a large phase 3 study, but we do post-marketing studies in the phase 4 clinical trial, and those are usually looking at thousands of individuals and what those outcomes look like. So now that we spent the first 5 minutes talking about some language that I'll be using, I'm going to be jumping into the top 10 clinical trials from San Antonio. I will tell you that it's not going to touch on all the subtypes or potentially all the interest in other clinical trials that were presented, but I believe that these 10 were the ones that were probably the most clinically impactful as a clinician. So let's first start with updates for HER2 positive metastatic breast cancer. I'm going to be specifically talking about the Destiny Breast 02 and Destiny Breast 03 studies. So both of these studies actually used a drug called TDXD, or trastuzumab deruxtecan. Destiny Breast 02 was actually a randomized phase 3 open label multi-center study, and it included patients with HER2 positive metastatic breast cancer that were previously treated with TDM1, also known as Kadcyla. They were basically randomized in a 2-to-1 fashion, and one of the groups got the TDXD, that's given IV every 3 weeks, and another group was given the physician's choice. So that could have been either trastuzumab and capecitabine or lapatinib and capecitabine. And the primary endpoint of this study was progression-free survival, and a key secondary endpoint is overall survival. So you'll see here, this is a Kaplan-Meier curve. You're going to see a lot of these in today's presentation. On the y-axis, you'll see that there's progression-free survival and the probability of that being presented as a percentage. And on the x-axis, you'll see time in months. In this Kaplan-Meier curve, what's really striking is that the median progression-free survival showed that trastuzumab deruxtecan, TDXD, actually reduced the risk of progression compared to the physician's choice. So if you look at the top right box, you'll see that that was 17.8 months for the arm with the trastuzumab deruxtecan, the TDXD, and it was just 6.9 months in the physician's choice. That was very statistically significant. An easy way to tell is when you look at this, if you see a large separation between those two curves, that is a significant difference between the two. Now, if you look at 2 time points, for instance, at the 12-month time point, there were 62.3% of people who received the trastuzumab deruxtecan that were free of progression versus only 27.2% in the arm of physician's choice. And if you move out a little further to 24 months, you'll see that there were 42.2% people that were free of progression at that 2-year mark, compared to just 13.9% receiving the physician's choice. So this is a stark difference. Now, the key secondary endpoint was overall survival, and you will see here, once again, the box on the right-hand side, in terms of the median overall survival, that was 39.2 months in the arm that got the trastuzumab deruxtecan and 26.5 in the physician's choice arm. Really, the takeaway message from this is that trastuzumab deruxtecan significantly improved progression-free survival and overall survival compared to the physician's choice for patients who had HER2-positive metastatic breast cancer previously treated with TDM1. Now, Destiny Breast 03 included metastatic HER2-positive patients. These patients were all previously treated with trastuzumab and a taxane in the metastatic setting, or they were treated in the neoadjuvant setting but had a very quick recurrence, which is defined as within 6 months of finishing that therapy. In this particular study, patients were randomized 1-to-1, so they either got the trastuzumab deruxtecan or they got TDM1. The primary endpoint in the Destiny Breast 03 study was progression-free survival, and a key secondary endpoint was overall survival. In terms of the progression-free survival, and this is by BICR, which is Blinded Independent Central Review, you'll look at the box all the way on the right-hand side. The median progression-free survival was 28.8 months in those that received trastuzumab deruxtecan, and only 6.8 months in the individuals that received TDM1. Once again, very statistically significant. We often use a p-value to describe the chance that that could have been by chance. And you'll see here it's less than 0.000001. And when you look at this particular figure, there's a huge difference between the two curves. What you'll see is that at the 12-month mark, 75.2% of people who were receiving the trastuzumab deruxtecan were free of progression at 1 year, compared to only 33.9% that were receiving TDM1. If you move out further to the 24-month time point, similarly, 53.7% who were free of progression receiving the trastuzumab deruxtecan versus just 26.4% in those that received TDM1. And in terms of the key secondary endpoint, overall survival, these actually haven't been reached just yet. It takes a little bit more time with clinical trials, oftentimes, to see the endpoint of overall survival, but it is statistically significant in terms of a difference. Like I said before, when you look between the two, the curves are separating. The p-value is quite small at 0.0037. At 12-month time point, 94.1% were alive in those that had received the trastuzumab deruxtecan versus just 86% with the TDM1. At the 2-year time point, 77.4% alive that had received the trastuzumab deruxtecan versus 69.9% in the TDM1 arm. So those were really the two major updates in metastatic HER2 positive breast cancer. I will be spending probably the majority of this talk talking about updates for hormone receptor positive breast cancer. These were just the most robust for San Antonio this year. So briefly, I'm going to first talk about the metastatic setting. I'm going to specifically talk about the Right Choice study, Capitella 291, Serena 2, Emerald, and PACE. And then I'm going to talk about the early stage setting. We had a bunch of updates, including Monarch E, the positive study, and TAILOR-X. So let's talk about Right Choice. This was a phase 2 study. It's actually the first head-to-head comparison of endocrine therapy plus a CDK4/6 inhibitor versus chemotherapy. So mind you, these are patients that had no prior systemic therapy, and they actually had very aggressive disease. They had symptomatic visceral metastases or a rapid disease progression or were markedly symptomatic with non-visceral disease. In this particular study, patients were randomized 1-to-1. They either received ribociclib at 600 milligrams, a standard dose with 3 weeks on and 1 week off, in combination with an endocrine therapy such as letrozole or anastrozole with guzrelin. I should add that these were all pre and perimenopausal women. So that's why the endocrine therapy combination looks like that. And then the other arm actually got the investigator's choice. So whenever we have patients that really have a lot of aggressive disease and we need to kind of rein in control, you'll see the use of 2 chemotherapy agents. So in that physician's choice arm, those patients either received docetaxel and capecitabine or paclitaxel, gemcitabine, or capecitabine and vinorelbine. These are all a combination of IV and oral chemotherapies. During this study, patients were monitored every 6 weeks for the first 12 weeks, every 8 weeks for the next 32 weeks, and then every 12 weeks. The primary endpoint for the study was progression-free survival. So if you look at the top right chart, you'll see that in those that received both the ribociclib and the endocrine therapy, the median progression-free survival was actually 24 months versus just 12.3 in the chemotherapy arm alone. So very significant difference. Once again, the curves separating out. Really, the take-home message from this is that, first line ribociclib plus endocrine therapy achieved a statistically significant PFS benefit of 1 year over the combination chemotherapy in aggressive hormone receptor positive breast cancer in individuals who are pre or perimenopausal, even if they had a visceral crisis. Here, you'll see similarly, in most of these populations, it really did favor the ribociclib and endocrine therapy arm. Ultimately, this was a benefit that was seen across most subgroups, whether, there was visceral crisis or not, the disease-free interval, whether or not there were liver metastases, or they were separated by age. Now I'll jump into Capitella 291. This was a phase 3 randomized double-blinded placebo-controlled study. It's looking at a new AKT inhibitor. It's called capivasertib. And this particular study was comparing capivasertib plus fulvestrant versus fulvestrant alone. Ultimately, it found that the combination provided some meaningful improvements in progression-free survival. This particular study included men and pre and postmenopausal women. They all had a recurrence while on or less than 12 months from the end of their adjuvant aromatase inhibitor or progression while on an aromatase inhibitor. No more than 2 lines of prior endocrine therapy, no more than 1 line of chemotherapy, and about half of patients actually got a CDK4/6 inhibitor previously. In this particular study, everyone's randomized 1-to-1. So they're either getting capivasertib at 400 milligrams twice a day. They take it 4 days on, 3 days off, and fulvestrant, which is given intramuscular day 1 and 15 initially, and then every 4 weeks. Or they get the placebo, 2 pills a day, 4 days on, 3 days off, and the fulvestrant. The primary endpoint of the study, as I gave away before, was progression-free survival. And they were looking at this in all the patients. And then they also looked at this with individuals who had this AKT pathway altered tumor. And the definition of that is having a specific mutation like a PIK3CA, an AKT1, or P53, also known as a PTEN alteration. So if you're wondering, why exactly that is, you'll see that oftentimes in this setting, we're giving people fulvestrant, but actually capivasertib is working a little higher up. It's working through a few different pathways, which is why those particular mutations that I just mentioned were specifically assessed in terms of a subpopulation analysis. Now, in terms of progression-free survival, you'll see here that those that got the capivasertib and fulvestrant had 7.3 months of median progression-free survival versus just 3.1 months in those that got the placebo and fulvestrant. And that was statistically significant. This was also true in the overall population as well. And so, the takeaway from this particular study was that the addition of the capivasertib to the fulvestrant extended the progression-free survival in both the populations, the overall and those that had this AKT pathway alteration. Now, I briefly just want to discuss the oral SERD landscape, because there have been so many studies that have specifically focused on this. And I'm going to talk about SERENA-2 and EMERALD next. There has been a lot of excitement about oral SERDs, as you can imagine. The fulvestrant is an intramuscular injection. And so when we really think about quality of life, having an oral option is really quite appealing. There are some other studies that were actually negative that were previously conducted, but we now have 2 positive studies that I'm going to talk about. So let's first talk about SERENA-2. This was a phase 2 study. It compared fulvestrant with camizestrant. So like I said, these are oral SERDs. These are selective estrogen receptor degraders. So SERENA-2 was looking at patients in the second-line setting. So they had basically a recurrence or progression on at least 1 line of endocrine therapy. There's no prior fulvestrant use. And you'll see here that it's predominantly postmenopausal women that are stratified to either the lower dose of camizestrant, 75 milligrams, or the higher dose at 150 milligrams, or fulvestrant. They did add a last arm to test a higher dose level of 300 as well. The primary endpoint was progression-free survival here. So what you'll see here is that overall, camizestrant significantly prolonged progression-free survival compared with fulvestrant among these postmenopausal women with advanced estrogen receptor positive breast cancer. So if you look at the chart on the top right, you'll see that in the camizestrant 75 and camizestrant 150 milligram dosing, the median progression-free survival were 7.2 and 7.7 months. And in the fulvestrant arm, it was just 3.7 months. And this progression-free survival was seen in patients even with prior use of a CDK4/6 inhibitor. So you'll see here on the left-hand side, this is specifically looking at that population. The median progression-free survival with the camizestrant was 5.5 and 3.8 months, and compared to just 2.1 months in those that received just the fulvestrant. And in the figure on the right-hand side, you'll see that at both the camizestrant 75 milligram dose and definitely in the 150 milligram dose, there was a median progression-free survival of 7.2 and 14.7 months compared to 9.2 in the fulvestrant arm alone. They also looked at it in individuals that had an ESR1 mutation. So here you'll see that the camizestrant 75 milligram and 150 milligram dose had a median progression-free survival of 6.3 and 9.2 months, compared to just 2.2 months in those that received fulvestrant. There was also an assessment of those that did not have an ESR1 mutation detected. Ultimately, in this subpopulation of patients with this ESR1 mutation, this is the figure on the left-hand side, camizestrant at both of these doses produced a clinically meaningful improvement in progression-free survival. And here we have the EMERALD study. This is a phase 3 study, and it looked at the use of elacestrant. So the takeaway message from this one was just that the longer duration of the CDK4/6 inhibitor therapy in the metastatic setting appeared to be associated with extended progression-free survival in those that received the elacestrant. So this study included men and postmenopausal women with advanced metastatic breast cancer. Everyone was ER positive, HER2 negative. They'd progressed or relapsed on or after 1 or 2 lines of endocrine therapy, one of which was a CDK4/6 inhibitor, no more than 1 line of chemotherapy. They were randomized to either this oral SERD, the elacestrant 400 milligrams daily, or the investigator's choice, or the standard of care. That includes fulvestrant, anastrozole, letrozole, exemestane. There were actually 2 primary endpoints. That was progression-free survival in all of the patients on the study, and also specifically looking at the progression-free survival in those with an ESR1 mutation. So if you look at this, these are the results for progression-free survival by duration of CDK4/6 inhibitor. You'll see that overall that there was a 30% reduction in progression-free survival, and you can break that down into whether patients were on the CDK4/6 inhibitor for less than 6 months, at least 12 months, or at least 18 months. So looking at the charts on the bottom, starting with the one all the way on the left-hand side, the median progression-free survival was 2.7 versus 1.9 months for those that received the elacestrant versus the standard of care. It was 3.78 versus 1.91 for median progression-free survival for those that were on it for at least 12 months, and 5.45 versus 3.29 months for those on it for at least 18 months. So even though you see this reduction PFS, these numbers aren't as significant as the next slide that I'm going to show you. So what was special about this is that they did look at a very specific population. So I had just presented the results from all the patients on the study. They actually looked at the ones with the ESR1 mutation, and there is a significant difference when you look at the bottom half of this chart. So if you look at those that were on the CDK4/6 inhibitor for less than 6 months, 6 to 12, 12 to 18, and greater than 18 months, this is a very pronounced effect on the ESR1 mutated population, and especially with longer use of the CDK4/6 inhibitor, especially those that were on it for at least 12 months. So for instance, for those that were on it for less than 6 months, that median progression-free survival, about the same, 1.87 in both of the arms. For the 6 to 12 month time point, similar, 1.91 to 1.84, but really big, quite a large difference noted in those that were on it for 12 to 18 months. That's a 5.49 versus 1.84 month difference. And for those that were on it for at least 18 months before progression, that's at 8.61 versus 2.10 change. Ultimately, across all of these subgroups, there was a 45% reduction in the ESR1 mutant subgroup. and there was a 53 to 70% reduction in the progression-free survival for those that were on a CDK4/6 inhibitor for at least 12 months. So that is a very stark difference. That's actually contributed to the FDA approval. So on Friday, the FDA did approve elacestrant for this particular setting. So that is for ER-positive, HER2-negative, ESR1 mutated metastatic breast cancer. Ultimately, the dose that was approved by the FDA last week is 345 milligrams. It's oral, it's with food, once daily until disease progression. In terms of this medication, this oral SERD, really the most common adverse events that were reported, that's in frequencies over 10%, were musculoskeletal pain, nausea, increased cholesterol, increased AST, triglycerides, fatigue, decreased hemoglobin, GI symptoms as well, including constipation, abdominal pain. So this was really quite practice changing. I think we're going to see a lot of movement as this drug gets to the United States now and goes to the specialty pharmacies, and as we ensure that the appropriate populations are being selected for the use of this oral SERD. And I'm also presenting the PACE study. This was actually a negative study, but I think it speaks to some important questions that we did have regarding the use of CDK4/6 inhibitors after progression on a CDK4/6 inhibitor. So the PACE study included hormone receptor positive metastatic breast cancer patients. They'd all progressed on their CDK4/6 inhibitor with the endocrine therapy. Didn't have more than really 2 lines of endocrine therapy, and none had prior fulvestrant. These patients were all randomized in a 1:2:1 fashion. So they either got the intramuscular fulvestrant, they either got the fulvestrant with continued palbociclib, that was at the standard dosing of 125 milligrams orally for the first 21 days and then a break week, or they got the fulvestrant, the palbociclib, and they got an immunotherapy called avelumab. That's IV every 2 weeks. So throughout the study, they actually did check different blood work, ctDNA, circulating tumor cell blood, things that we are still researching. The primary objective of this study was to look at the progression-free survival for the first 2 groups. That's the fulvestrant and palbociclib versus fulvestrant alone groups. If you look at the progression-free survival in these 2 specific groups, that's the intended population, the intention to treat population. The median progression-free survival was actually 4.8 months in the fulvestrant arm and 4.6 months in the fulvestrant and palbociclib arm. So really not a significant difference. And actually there was no significant difference noted even with the immunotherapy arm. Mind you, that's not their primary endpoint. That was not their primary intention of the study. It was an additional endpoint that they were looking at. Ultimately, I think that, the takeaway from this is that, among patients that have hormone receptor positive metastatic breast cancer, combining a CDK4/6 inhibitor such as palbociclib with fulvestrant beyond progression on that existing CDK4/6 inhibitor really doesn't significantly improve the progression-free survival compared to just using fulvestrant alone. I do think that the study suggests that we should do longer observation for progression-free survival with the arm that received the immunotherapy, the avelumab. That's a PD-L1 inhibitor. And I think that there's an interesting signal here and really just deserves further study. All right, and now I'm going to just jump into some updates in the early stage hormone receptor positive breast cancer setting. We'll start with Monarch-E. So this includes patients with hormone receptor positive early stage breast cancer that's node positive and considered high risk. So this study included men or women the women were either pre or postmenopausal, and they could have had neoadjuvant, adjuvant therapy, chemotherapy or not. Obviously, no evidence of metastatic disease, and a maximum of 16 months from the surgery to the time they were randomized on the study, and a maximum of 12 weeks of endocrine therapy following the last non-endocrine therapy. So Monarchy had two cohorts. So one was high risk based off of clinical pathological features. What that means is they had, many nodes involved, at least that's defined as at least 4 axillary lymph nodes, or they had 1 to 3 axillary lymph nodes that had cancer and was high grade, or a very large tumor defined as being greater than 5 centimeters. There's another cohort that was classified as high risk, and that's based off of a Ki-67. That's a pathological description of how quickly a cancer cell is proliferating or making more of itself. So in cohort 2, these included patients that had 1 to 3 axillary lymph nodes with cancer and a Ki-67.
Oh, Dr. Shang, you're frozen. Hopefully she'll be back. This has never happened before.
The other arm received standard endocrine therapy, so either an aromatase inhibitor or tamoxifen. In terms of the total treatment period, it was 2 years. And then the follow-up period was an additional several-year period. In terms of the primary objective, it's invasive disease-free survival, IDFS. So the update actually showed an increasing benefit from abemaciclib to endocrine therapy in this particular setting, in the adjuvant setting. So if you look at this figure, you'll see foremost that the chart shows that in those that received the abemaciclib and the endocrine therapy, there was a stark difference in the number of total events compared to those with endocrine therapy alone. So there was 336 events in the abemaciclib and endocrine therapy arm, and there were much more, 499 events in the endocrine therapy alone arm. If you look at the figure on the y-axis, it's the percent that had invasive disease-free survival, and on the x-axis, it's time. And if you look at, a time point of 2 years, 92.7% of people receiving the abemaciclib and the endocrine therapy were alive and free of invasive disease at that time point, versus just 89.9% of people in the endocrine therapy alone arm. And if you move out to 36 and 48 months, you'll see that the curves actually start to come apart even more. So it's actually suggesting that this response actually deepens with time. So at the 36-month time point, you'll see that 89.2% of individuals were alive and free of invasive disease versus just 84.4% in the endocrine therapy alone arm. And at the 48-month time point, 85.8% were alive and free of invasive disease versus just 79.4% in the endocrine therapy alone arm. And this was actually pre-planned interim analysis for Monarchy that really showed this absolute improvement in disease-free survival at 4 years. What's also interesting is that the Ki-67 was prognostic, but actually not predictive of abemaciclib benefit. So if you look at this chart here, you'll see that for those that were in cohort 1, that's the Ki-67 high group, in terms of the total number of events and the disease-free survival between these two groups, there's really no big difference between all of these. And if you look at the arms here, there's numerous and many more lines here essentially, but the two on the very top are the cohort 1, that's the high Ki-67, and then you'll see the two lower ones are the Ki-67 low. And regardless of whether they had high or low, those that actually got the abemaciclib, that's the red line, did have a higher chance of having invasive disease-free survival. Now we'll move on to the positive study. Essentially, this just showed us that young women with early hormone receptor positive breast cancer who temporarily stopped endocrine therapy to attempt pregnancy experienced similar short-term recurrence risk as those who did not stop. So in terms of the study design, the planned endocrine therapy interruption was actually a total of 2 years. So that includes time to attempt pregnancy, to conceive, to deliver and breastfeed. It also actually includes a 3-month washout from endocrine therapy. And if there was no pregnancy achieved by 1 year, fertility assessment was strongly recommended for those that were wanting to pursue family planning. Endocrine therapy resumption was strongly recommended after pregnancy so that people could complete either their 5 or 10 years as per the discretion of their medical oncologists. And there was also obviously long-term follow-up on it. So if you look at this figure here on the very bottom, you'll see everyone on the study was on endocrine therapy for somewhere between 18 to 30 months. They stopped the endocrine therapy. They did a 3-month washout. And then they took a total up to 2-year break to allow for conception, delivery, breastfeeding, and then were all advised to resume their endocrine therapy. In terms of patient characteristics, actually just 1/3 of women who were on the study were below the age of 35. The majority were between the ages of 35 to 39, and 1/4 of them were actually between the ages of 40 to 42. Majority of them, 75% of them, had not had a prior birth. And most of the women did have early stage breast cancer, so that's stage 1 or stage 2. In terms of the pregnancy outcomes here, 368 or about 74% of the 497 women in this particular population had at least one pregnancy. So that's for a total of 507 pregnancies. And 317 had at least 2 live births. 64% of essentially all the women and 86% of those who actually became pregnant. Here we're looking at breast cancer-free intervals. Really, the takeaway from this is that at 18 months, which was the landmark analysis time point, those who became pregnant did not have a significantly higher breast cancer-free interval event. Here you'll see that there really wasn't a significant difference between the two. In terms of the y-axis, it's the cumulative incidence of the breast cancer-free interval, and the y-axis is the months that passed, whether it's 6, 12, or 18 months, and whether patients were in the arm that had no pregnancy, that's the red one, or got pregnant by that 18-month time point, that's the blue line. Really, there was no significant difference between the total number of events. In terms of looking at competing risk, because that was certainly important to evaluate at the 4-month time point, about 8% of these women did have a cancer recurrence or death before resuming their endocrine therapy. 76% resumed the endocrine therapy, and then 15% had not resumed their endocrine therapy at the time of the presentation. Ultimately, 79% of women were disease-free at 2 years in terms of those who hadn't yet resumed their endocrine therapy. And we have TLRx. So this was a 12-year update. These were patients that were all recruited for the TAILORx study between 2006 to 2010. So last recruitment was about 13 years ago. These included patients that were node negative, that were estrogen receptor positive, HER2 negative, and had any tumors that were considered smaller T1C to T2. All of the patients got an Oncotype DX. And that was over 11,000 patients that had pre-registered. Ultimately, they had over 10,000 that did register on study. The purpose of this TAILORx study was really to focus in on the intermediate risk population. So if you look right smack dab in the center of this chart, that's the mid-range with a recurrence score of 11 to 25. This included over 6,000 individuals that were included in either an experimental arm, which was endocrine therapy only, or endocrine therapy and chemotherapy. For the other two arms, it's pretty straightforward. All of individuals who are low risk get endocrine therapy already. All the individuals who are high risk, defined as a score of 26 and higher, end up getting a recommendation for chemotherapy and endocrine therapy. It's really the intermediate risk group where there still tends to be a conversation about the risks and the benefits. So, the main study findings were unchanged for this intermediate risk group. So those findings were previously shared through publication and conference, not surprising to many. In terms of these two groups, endocrine therapy is it's non-inferior to chemotherapy and endocrine therapy. And that really speaks to the overuse of chemotherapy prescription prior to the use of using the Oncotype recurrence scores. And here, these are just more specific numbers. So when we look at the 5 and 12-year update, really the numbers are very similar to each other. So if you look at these two arms, you'll see that whether you were in arm B that got the endocrine therapy or arm C, the chemotherapy and the endocrine therapy, the outcomes were very similar. So IDFS, invasive disease-free survival, at 5 years was 92.8% versus 93.1%. Very similar. At 12 years, which is the most recent, very similar, 76.8 versus 77.4%. Essentially a lot of these outcomes, when you look at them between the arms, were comparable in their frequencies. The DRFI, that's the distant and local regional recurrence, at this most updated time was 92.6% in the endocrine therapy alone arm versus 92.8% in the arm that got the chemotherapy and endocrine therapy. Or even overall survival at 12 years was quite similar between the two groups. It was 89.8% versus 89.8% for those that received the chemotherapy and endocrine therapy. So ultimately, all the conclusions are really pointing to all the advancement that is constantly in this field. And I think we are moving the needle forward. We are continuing to strive to improve breast cancer outcomes. I think one of the wonderful things about this space and this time is that there are new drugs, new studies, new information to share every single year. And that I really believe that we're slowly improving treatment for early stage and advanced disease for breast cancer patients. So I just want to say thank you for all of the individuals that receive care at Hopkins and contribute to research so that we can continue to learn more about how we can give better care and develop better drugs. And it's been a pleasure, and I'm happy to take any questions people may have.
Thank you so much, Dr. Sheng. And in the chat, there's, I believe, 2 questions that I don't know if you want to read them, if it's easier, or if you want me to read them.
Do you want to read them?
Sure. So the first question is, was there any discussion of the relative toxicities of the different treatment modalities?
So actually in in some of the presentations, I presented many studies, 10 studies, and none of them were single arm studies. They all had at least, 2 arms, and they do describe the frequencies of different side effects and toxicities. You just would have to get access to the slides. Some of them often are frequently followed by a publication, which is in a publicly accessible journal. So I definitely think that that's important. That's why I focused just briefly on the elacestrant, because that was just FDA approved. And so a big question people always have is, if something is efficacious and possibly going to be given to a patient, what does that quality of life look at? What are the side effects we're looking at? So yes, most of the studies do have one slide focusing on toxicities and differences between the arms. That's a good question.
Okay, great. And then the next question is, ER/PR positive and HER2 positive completed 1 year of tamoxifen, now on letrozole, and is it gacerin? I'm having such a hard time with the side effects from the hormonal treatments. This has really affected my quality of life. Also don't want to get cancer again. Do you have any advice?
Yeah, so this is, I really feel for who wrote this.
Well, we're not going to use names. Yeah, and it doesn't have a name, just
okay.
Right.
So I think this really speaks to how difficult endocrine therapy is. Obviously, it's a different experience for each person, whether you're on an oral agent only, such as tamoxifen endocrine therapy, or you've also been recommended the ovarian function suppression, basically a pharmacologic menopause. There are, of course, certain people who have very minimal side effects, probably about half of people, but then the other half of people have pretty moderate to severe side effects. And so, I think symptom management is probably a shared decision, a shared process in terms of provider and patient. Obviously, we can't get into details here, but I always say, tell your provider what you're experiencing. For instance, the number of hot flashes you had. Do you have vaginal dryness? Do you have issues when you're being intimate? Any of those questions really needs to be directed to a physician, because we do have more information now about some pharmacologic treatments for each of these things, which can really ease that. Obviously, you're on the endocrine therapy because it reduces the risk of recurrence by over 50%, but there's also the quality of life issue. So I really would encourage a discussion with your medical oncologist.
Thank you so much for saying that, because quality of life issues are so important. So the next question is, you mentioned, I believe ET is endocrine therapy for either 5 years or 10. Has there been a difference in overall survival between those two?
So the discussion about extended endocrine therapy has to be done on an individual basis. And so there are numerous studies that have looked at extension by 5 years, also some studies for 2 years. Ultimately, we have to look at your risk of recurrence. We have certain calculators that can help us do this, but it's not a blanket recommendation for all patients. It's going to depend on your recurrence risk at the 5 to 10 year time point. We have CTS5 calculators. There's the breast cancer index as well. So there are a few different options in terms of what can be done to help you evaluate, is there added benefit in another 2 years or another 5 years versus potential side effects with either of the oral endocrine therapy agents.
Okay, and then sort of piggybacking on that, somebody asks, what is the downside of continuing the endocrine therapy longer than 10 years?
Yeah, this is a great question. This is oftentimes coming from someone who has actually typically had very minimal side effects, which is why they can often get to the 10-year time point and they're saying, can I go longer? Why can't I continue longer? I will tell you that it's been shown that there is increased bone health issues or osteoporosis, increased risk of fracture. We now know that there's increased cardiovascular disease with extended aromatase inhibitor therapy. So, you want to think about, how do you maximize this drug, right? You want as much benefit with as little side effect as possible. But the concern is that you might have maximized a lot of benefit and now you're just going to have increased risk in terms of other comorbidities. So no nobody using evidence-based medicine is recommending beyond 10 years right now.
Thank you. That's so helpful. So then the next question, first the person said, thank you for this, Dr. Shang. Any new findings relative to new treatments for TNBC, specifically staying on hormonal therapy beyond 5 years as an added benefit?
Yeah, so as I was preparing these slides, I was thinking about that and how I didn't have any studies for the triple negative space, which is so important. I will say that, every year at San Antonio, those studies, there's just a lot of variation. I could say there's other years where it's been all HER2, it feels like, and other years where we had some really exciting developments in the triple negative space. And I think this year it was just a strong focus on the hormone receptor positive population. So in terms of clinically impactful, going to change something, or an really exciting drug that's gone through like phase 2, phase 3, unfortunately, I did not find that for San Antonio this year. And then I think the second question was about hormonal therapy beyond 5 years. I think in the triple negative population, we're really talking about use of chemo prophylaxis or chemo prevention. And so it's a separate question. And I would say most studies don't show benefit beyond 5 years for that particular question.
Okay, and I don't see any other questions, so I don't know if anybody has any. I know you had extensive slides, and I'm imagining people want to see. Okay, so somebody just put in the chat, is there any new treatment to prevent return of lobular breast cancer?
That's a good question. Lobular breast cancers are unique and different from the more common ductal breast cancers. We know that lobular cancers tend to be less sensitive to chemotherapy. And so the focus on reducing the risk of recurrence for lobular breast cancer has often been focused on the use of endocrine therapy. In terms of other new agents, that's going to be very dependent on the subtype, what's the hormone receptor positive status, are they HER2 positive, et cetera. But I hope that answers that question.
Thank you so much. And I know it's 7:30. People are saying thank you. Oh, one other person just said, I didn't catch anything about ER positive, HER2 negative, lymph node positive, but not considered high risk for recurrence.
Yeah, there was nothing this year for this particular population. In the year prior, there was the RX Ponder study that looked at patients with hormone receptor positive breast cancer that were lymph node positive, but none for this year. Like I said, there's a lot of flux from one year to the next. And so, if you listen to this talk next year, it's going to be a totally different landscape potentially and focused on different other subtypes or different settings, metastatic versus early stage.
Yes, that's such a good point. And I just want to thank you, and so many people are writing in the chat as well. Thank you so much for spending, this evening with us, for going through such detail in your slides. And I don't know when they'll be available, but I do imagine that people will want a copy of them because they were so detailed. And I just also love that they were so easy to see, because we've had presenters in the past where it's been harder to read those slides, and it really was easy to see and follow you. And, again, just so appreciate you being here tonight with us. And thank you everybody who attended tonight's program. I am going to send out an evaluation that really just helps us with all of our programs. So if you could fill it out, that would be wonderful. And also to, when I do have some slides available, I will let you know. And, Dr. Shang was sweet enough to say that she would share them with us. So
yes, thank you. Thank you so much for inviting me. And I'm glad to share my slides with you. I'll email them to you so you can distribute them.
Okay, thank you so much. And I hope everybody has a great night.
Thank you.
Good night, everyone.
Good night. Thank you so much.